So here's our basics of parafunctional occluding schemes. Here's this full coverage splint. This patient showed up in my office in San Diego. He came down from Newport Beach. He had been told that he needed surgery on his left joint because it was really, really painful, uncomfortable, difficult to work with all the time. Finally found a dentist who made him a really nice splint. And you can look at this, you could tell someone's put a lot of work into it. So why is he seeing me? Still has headaches, sometimes migraine, and his left joint still hurts kind of, but not like it used to. What can I do for this guy? What do you see right now? Teeth are touching all over the place in the photograph, so you know this guy can clench like nobody's business if he needs to. That primary clenching is uncontrolled right now. Move your jaw to the side. Well, so that problem, not fixed. Move your jaw to the side. Immediate posterior disclusion on both sides. I have no contralateral ipsilateral load or contralateral strain. I've got that problem out of the way. So then this guy's joint does feel better than it used to. It's okay. So as I look at what my opponent is capable of, I've taken that shot away from him. Well, he's got canine to canine contact. He can clench right there with about 80% of maximum. It's a pretty stable anchor. So that lateral pterygoid is pulling towards the canine. At least it's not cross arch and pulling medially. That's the worst direction to pull. So now we've changed the force vector from cross the arch medial to a little bit more of an anterior. Now we're at an anterior direction. So we've improved the strain on that condyle. It's designed to go forward, not medial. So let me have this guy protrude, and now we're at incisal edge-to-edge and protrusion. So I've got the minimal protrusive resistance. Edge-to-edge contact, no posterior contact. And this is, you can't get that much thinner, so it's minimally rotated. Now, if this thing was really big and thick, I suspect he'd hurt when he went forward and squeezed, and we'll show examples of that later on. That's the problem with this guy. He has the ability to clench canine to canine, and he continues to do so. So splint therapy goals are, first, to relax the musculature. There's no such thing as relaxing musculature. There's reducing the intensity of the muscular contraction by eliminating some of the circuitry. It's still going to be contracted. It's just less intense. Well, a full coverage splint lets you get beyond your voluntary maximum. Incisal edge contact, Barry will show this on the EMGs, you'll get about 30% of temporalis maximum. Why don't I care about the masseter? Because it gives up after a while anyway. It's not going to go all night on me. So let's take a look at what an anterior deprogrammer that we use to deprogram the lateral pterygoid early on. How can we use that in a therapeutic manner? Here's your anterior deprogrammer. Best bite discluder looks like this. Panky bite stop looks a lot like this. For chair side application, tap, tap, tap. You want to get a lateral pterygoid to deprogram, you can a little bit. But if it's at a certain length and needs to get longer, grow longer, it's not going to happen in the chair. For a night or two, this might be okay. We assume people will clench and grind as hard as they can. That's why Dr. Dawson asks these patients that. Let's assume this person clenches and grinds as hard as they can. At least we're looking to get canine rise to transfer to incisal guidance. So let's assume that since this person's mandible has gone to the right, if this person goes to the right, you get canine contact on the side of the translated condyle. So where we thought we were going to get canine rise here for immediate posterior separation, there's going to be a canine contact over here. Don't wear a deprogrammer at night. It'll cause internal derangement. You ever heard that one? Of course we have. How is that possible? It's possible by what you do. What if you don't do this in your primary centered clencher? A deprogrammer is perfect. But if they're going to do that, you're in a world of hurt. You may have to enhance the design of the deprogrammer to stay away from your enemy. So when you modify this upper deprogrammer, that's how this NTI thing started to happen. Well, but when you start to solicit to more and more difficult patients, This isn't a problem for parafunction to figure out. Why doesn't the jaw just keep going until the canine who's been sent out on a search and destroy mission finds your deprogrammer and splits it in half? People in a migraine clinic, they are the clenchers extraordinaire. We talk about opposing devices and slide bars. I'm doing that more because my patients split them in half. And they're so cute and adorable, 24-year-old college girls that couldn't hurt a fly, but my God, they'll destroy stuff in their mouth. It's amazing. So if that's the problem, and you can't give the temporalis the opportunity to do that to you, you need to change the topography. Here's the same jaw position. So a lower device is still on an incisal contact. So my default is now to make the device on the lower as often as I can. We'll see later on what makes this awkward to do and when you would use an upper instead. Mike Melkers has a whole DVD just on this chairside application and as you transition into a restorative case and on and off your articulator. So does this incisal contact distalize the condyle? Here's mastication against a bolus with maximum contraction intensity of these elevators. Here's your incisal contact. The moment that touches, this drops down to 30% of maximum right here. This fulcrum arm is still here, but now, or this lever arm, but now the fulcrum's here. The force vectors are still in the same direction. So the direction of the condyle is still the same. There's nothing to make the thing go backwards. It's because the use of this articulator has distorted our assumptions about an NTI device. If you were to drop the mandible like you should and drop the pin too much like it was an NTI device, you'd notice that the pin gets clobbered by the slope of that table. If you wear an NTI device, an upper NTI, this is the excluding out of an upper NTI, and you slope it too much, and you elevate against that, your incisors get bent lingually, get knocked lingually. In the chair, nobody will go bam, 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 go, oh gosh, killing me. They will touch it and pull back. They'll touch it and pull back. They'll touch it and pull back. And if they've got a joint where they go, oh, it hurts. If you didn't have them do that in the chair, they would have come back the next day and they would call you in the morning and say, my lower teeth are killing me. Because the forces are always going to be that way. If we used an articulator like this and put an NTI on these upper teeth at like this incisal guide pin, that'd be more obvious to people. But here's what you do. Instead, the articulator looks like this. You raise the maxilla, you drop the pin, and this gets distalized. And so we all know we take that pin and we pull it forward towards us all the time.